All right, so let's talk about our metabolic imbalances first. All right, so let's talk about metabolic acidosis. So this basically is a metabolic problem when there is a buildup of acid in the body. So what are some things that can cause this? All right, so increased acid production. All right, so one disease process that you should know is DKA, so diabetic ketoacidosis. So remember, ketones are acids. So this increase of acids in the body with DKA, this could lead to the patient being in metabolic acidosis. All right, decreased acid secretion. So what organ is responsible for filtering out all our waste and filtering out our acids? The kidneys. So if the patient is in renal failure, then their kidneys is not doing what it's supposed to do. So there will be high amounts of waste and acids left in the body. All right, so we know that bicarb is heavily in our gastrointestinal system. So if the patient is experiencing diarrhea, they too will excrete a lot of bicarb. So what are our ABGs going to look like? So our bicarb is going to be less than 22. Our pH is going to be less than 7.35, and our CO2 can be 35. It can be less than 35, or it even can be normal. So remember, with metabolic acidosis, we're holding on too much acid. All right, so how is this patient going to present if they're in metabolic acidosis? So on your exams, you will have to read ABGs, but also you'll be given a patient scenario, and they will want you to figure out which acid-base balance that patient is experiencing. So if your patient has Kussmaul's breathing, this is rapid breathing. So remember, this patient is going to be breathing so fast to get rid of the CO2. Why don't we want the CO2? Do we remember from the patho video? So we don't want the CO2 because it is going to bind with water and then make carbonic acid, which then is an acid. And when it's broken down, it is going to break down into hydrogen ions, which will further decrease our pH, right, and make us more acidotic. So that patient is going to have that Kussmaul's breathing, which is going to be rapid breathing. This patient is going to be confused, right? So they're doing all that rapid breathing, so they're not getting the oxygenation that they need. So they may have some confusion. They will be weak. They'll have a low blood pressure, and this patient will see cardiac changes. This is so important. So this patient will experience hyperkalemia signs and symptoms. So cardiac changes are big. So remember that if a patient is in acidosis, that this causes potassium to move outside of the cell into the bloodstream. So it is so important to watch out for hyperkalemia signs and symptoms in this patient. All right, so what are we going to do for a patient experiencing metabolic acidosis? So the biggest thing is to treat the cause. So you remember the slide we talked about all the different type of reasons why a patient could be experiencing acidosis. We then want to treat that reason. So let's say that the patient was in DKA. We then want to treat the DKA, right? So we would give that patient insulin. We would give that patient fluids and things like that. But just remember, potassium will move inside the cell when you give insulin, which can cause hypokalemia. So we just want to be on the lookout for that. But we want to monitor our respiratory and our cardiac system. So you will need to have this patient on a cardiac monitor, especially if they are presenting with these symptoms of hyperkalemia, because you can see EKG changes such as tall waist. So we want to make sure that we're monitoring them. We want to be monitoring their respiratory status as well, because remember, they're going to have these Kussmaul's breathing, that really rapid breathing. You want to treat the hyperkalemia, right? So if that patient is experiencing hypokalemia signs and symptoms, you want to treat that. And then if the patient kidneys are not working, then this patient, they may need to go to emergency dialysis to get that acid removed off of them. So the biggest thing when it comes to treating these acid bases imbalances is to treat the cause. Treat what is causing that patient to hold on to acid. All right, so let's talk about metabolic alkalosis. So metabolic alkalosis is a metabolic problem caused by an excessive loss of acids or an increased amount of bicarb produced in the body that can lead the body to being in an alkalonic state. So let's look at some causes. So losing acid via the stomach. So if your patient has severe vomiting, right? If your patient is hooked up to NG tube suctioning for a long period of time, or continuous NG tube suctioning, this patient is going to be losing a bunch of acid. If your patient has a loss of potassium. So potassium loss can cause hydrogen ions to go inside the cell, which will drop the pH. So that's something to keep in mind. As you can see, that potassium plays a major role in metabolic. If your patient is on loop and thiazide diuretics, this can cause the kidney to waste hydrogen ions and chloride through the urine, which in return increases the bicarb, so your patient may need to be on a different type of diuretic. Also, your high aldosterone levels, they can cause metabolic alkalosis because aldosterone makes the kidney hold on to sodium and get rid of potassium and hydrogen ions. So when you're losing too many hydrogen ions, this makes the blood more alkaline. And also your chloride levels as well. Low chloride levels can lead to metabolic alkalosis, and infusing too much bicarb. So let's say that you were treating a patient and giving them bicarb, and now you gave them too much bicarb, so now you put them into an alkalonic state. So what are your ABGs going to look like? So your bicarb is going to be greater than 26, your pH is going to be greater than 7.45, and your PCO2 is going to be greater than 45, or it could be normal. All right, so how is this patient going to look? A patient who is experiencing metabolic alkalosis. So this patient is going to have hypoventilation going on, okay? So this patient is going to be breathing really slow. Why is this patient going to be breathing really slow? Because they're going to want to hold on to that CO2 so it can bind with water and make carbonic acid, and once carbonic acid, because it is a weak acid, it's going to break apart, it's going to break into hydrogen ions, so that can then increase the pH. Okay, so that patient is going to be breathing really slow. That patient is going to have hypokalemia signs and symptoms. So with alkalosis, the patient's potassium is going to move outside of the cell into the blood. So that patient is going to experience hypokalemia signs and symptoms. So this patient also, you want to have them on the cardiac monitor because you can see EKG changes in these patients as well. They will complain of muscle weakness, tremors, and they could be irritable. So the biggest thing is to know that your patient will be hyperventilating. Your patient will be breathing less than 12 respirations per minute. All right, so for metabolic alkalosis, what are you as a nurse going to do? So the biggest thing is to treat the cause. So whatever the reason is that the patient is experiencing alkalosis, you then want to treat that. So some other things is you want to monitor the EKG for potential dysrhythmias, okay? So we know that this patient is going to have a low potassium. So we want to make sure that we have them on the monitor so that we can see if the heart does any type of changes. Also monitor your respiratory status, because this patient is at risk for respiratory failure. So remember, these patients are breathing less than 12 respirations per minute. Also assess your neural status as well. You want to keep an eye on your electrolyte, especially your potassium and your chloride. So remember, chloride is a reason of why this patient is in alkalosis, and make sure that we're paying attention to our potassium, okay? And then you would just replace them as ordered by the physician. So if the patient is experiencing vomiting, right, we want to treat that cause. So if we can give that patient some Zofran or give them some Phenergan as the doctor ordered, we want to do that to minimize the loss of acids through vomiting. So we talked about those diuretics, the loops diuretics and the thiazide diuretics that can cause us to lose our acids. We then want to give our patient Diamox. This can be given, and this decreases your bicarb reabsorption. So the biggest thing to take away is that we always want to treat the cause. So how I would study is that I will look at the cause of why the patient is experiencing alkalosis, and then that is how I would build my nursing interventions. All right, so let's practice some ABGs. I know y'all are tired of me talking, so let's practice some ABGs.
All right, so I do my ABG calculations by doing the tic-tac-toe method. So you can easily draw out this little chart on your paper, and what you want to do is once you figure out what the pH is, you then will put it in the correct spot. And then if you have 2 in a row, that's what it is. So let's go over it because this may seem confusing. All right, so the question says that the pH is 7.31, the PaCO2 is 30, and the bicarb is 18. So I also put a little cheat sheet on the side of the screen for you, but make sure that you remember this because this will not be on your exam. So you're going to have to commit this to memory. Also, the pH down there, one thing I want to mention about the pH. So you can have a normal pH, but some questions require you to know if the pH is on the normal acidosis side, meaning if the pH is less than 7.40, it's going to be normal, but it is going to be on the acidosis side. So let's say if the pH was 7.35, that is considered normal, right? But it's on the normal acidosis side. All right, let's talk about if your pH was greater than 7.40. This is going to be on the alkalosis side. So let's say it was 7.43. Even though it's normal, it's on the normal alkalosis side. So I definitely wanted to point out these things before we go into working our problems because it'll make sense. So remember that you need to remember all of this because you won't have this on your exam. So remember your normal ranges. So normal ranges is 35 to 45 for your CO2. So the chart even says on here, if it is less than 35 is alkalosis. If it's greater than 45, acidosis. With your bicarb, normal ranges is 22 to 26. If it's less than 22, acidosis. If it's greater than 26, alkalosis. All right, so let's jump into our first problem. So our pH is 7.31. So let's start with there. All right, so our normal range for pH is 7.35 to 7.45. So this pH is below 7.35. So this pH is considered to be acidosis. So we're going to write pH under the acid area, okay? All right, so then our PCO2 is 30. So normal PCO2 is 35 to 45. So the PCO2 is low. So that's going to be considered alkalosis. So we're going to come over here and write CO2. All right, so the bicarb is 18. Normal bicarb is 22 to 26. So that bicarb is low. So that's going to go under acidosis. So we're going to write bicarb on here. All right, now we want to see, do we have 2 under the same column? And yes, we do. So we know that it's acidosis because we're under the acidosis column, and which is under the what is under the acidosis column? It is your bicarb. So bicarb is your metabolic. So we know that this patient is experiencing metabolic acidosis. Now we see that our respiratory, which is our CO2, is also out of whack. So we would have to say that the patient is experiencing metabolic acidosis and they are partially compensating. So what does that mean? That means that the body is now trying to compensate through the respiratory in order to bring this patient into a equal balance. All right, so the question says that the pH is 7.48. All right, so normal pH levels is what? 7.35 to 7.45. So this pH is high. So this pH is going to be considered alkalosis. So we're going to go over here and write pH. The PaCO2 is 41. All right, so normal levels is 35 to 45. So the patient is in normal range when it comes to the CO2. So we're going to go to normal and we're going to write CO2. All right. The patient's bicarb is 29. So normal bicarb ranges is 22 to 26. So this patient's bicarb is elevated. So this patient is experiencing alkalosis. So we're going to come over to the alkalosis chart and put the bicarb in there. So now we want to look at our tic-tac-toes. Is there anything that's lining up under both? Yes. So the pH is under alkalosis. So we know that this patient is in the alkalosis. And we see that the bicarb is under alkalosis. So this patient is experiencing metabolic alkalosis. Now, is there any compensation going on? No. Why not? Because the CO2 is normal. All right, so the pH is 7.50. So normal pH is 7.35 to 7.45. So this pH is elevated. So this patient is in alkalosis. So we're going to write pH under alkalosis. All right. So the PCO2 is 50. So normal levels are 35 to 45. So this patient is elevated. So they are acidosis. All right. The bicarb is 30. So normal bicarb levels is 22 to 26. So this patient has elevated bicarb. So that lets us know that they are in an alkalosis state. So we're going to put the bicarb under alkalosis. So then we're going to look at our chart to see, do we have any two in the same column? So yes, on the alkalosis, we have our pH and we have our bicarb. So we know that this patient is in metabolic alkalosis. Now, do we have compensation? Yes, we have compensation because our CO2 is in the acidosis column. So we know that the lungs are now trying to compensate to bring that patient back into a normal ABG range. So your answer is going to be metabolic alkalosis with partial compensation. All right, so the pH is 7.35. So normal levels is 7.35 to 7.45. So that is normal. So we're going to write it under the normal side. All right, and then the PCO2 is 48. So normal ranges is 35 to 45. So we're going to write that under the acidosis because it's 48, so it's a little elevated. So we're going to write the CO2 over here. All right, and then our bicarb is 29. So normal ranges is 22 to 26, so it's 29, so it's elevated. So it's going to go under the alkalosis side. All right, so we now want to look and see, do we have any under this? Do we have two under the same column? And we don't. So what we have to do is go back to the pH and figure out, is the pH on the acidosis side even though it's normal, or is it on the alkalosis side even though it's normal? So the pH is 7.35. So our little chart on the side said that if the pH is less than 7.40, it will be considered acidosis. So even though it's normal, it's on the acidosis side of being normal. So the pH would then go over here. It would then go on the acidosis side. Now we want to look and see, do we have 2 in the same column now? And the answer is yes. We have the CO2 and we have the pH. So this patient is experiencing respiratory acidosis. Now, is there compensation going on? Yes. Why is there compensation going on? Because the bicarb is also out of whack. But what type of compensation do we have going on? We have fully compensation going on. And how do we know that? Because the pH is normal. If the pH is normal, there is full compensation going on. So the answer is respiratory acidosis with full compensation.